you participating in today's webinar. We spoke probably with some of you about a month or so ago when we presented on the opportunity for Health Current to support the CMS new condition of participation around patient event notifications. But today's webinar and session is to speak with you about two new projects that we are excited to launch in two new service lines that will be able to support hospitals and health systems in automating what it has traditionally been manual reporting for different public health purposes. So we've got a set of slides today. There's only about 30 to 35 slides. So I would just encourage you to ask questions, put them in the chat if you have questions as I'm going through things. I'd like to get through the set of slides, and then we'll have plenty of time for open discussion, and I can go back to any slides. But really the purpose of this presentation is to give you some insight and some more detailed information about two new projects that are available for hospitals to participate in, and to answer any questions you have about those new projects. So really the agenda for this morning is to talk, for anyone who's not familiar with Health Current, I'm going to keep the About Us section extremely brief because if you're on this webinar, it's likely because you work with us regularly. I see a lot of names I recognize, and you're familiar with Health Current. But we're going to talk about what we do currently with public health, but the majority of the time we're going to really talk about these two new hospital HIE public health projects that are available for your facilities to participate in. So the About Us, we are Arizona's HIE. We actually crossed the threshold last week, and we now have over 800 participating organizations throughout Arizona. That was an exciting threshold to cross. We've just seen significant continued increase in long-term care and private practices and behavioral health. And for most of the other categories, we actually have really almost full and complete participation. So over 200 data sources sending medical records and data on over 12 million patients. So as we have grown, both in participation as well as in data suppliers, what there's an opportunity to use the data that flows from your facilities to the HIEs for more purposes. And that alleviates burden on your side. It saves time, it saves money, and you can use this one connection to the HIE for multiple purposes. So these are just some of our regular statistics. Again, we've got the majority of all the admission, discharge, and transfer information and emergency department data flowing to the HIE for the state, millions of transactions, hundreds of thousands of records accessed monthly. So we really continue to go really full force ahead. Our current connections with public health, even pre-pandemic, was limited to AZ peers, which is the ability for electronic case reports, electronic patient case records to come from fire and medical EMS providers through the state registry, the emergency trauma registry at AZ Peers, and come to the HIE. It was a way that we could bring additional data into the health information exchange. And the other one that we had pre-COVID was ACES, which was the immunization registry. So these are all the current public health connections. We've got the immunization registry. So if you weren't familiar, we do have a bidirectional connection to ACES. And also the last one on here, AZ Peers, was the other one that we had pre-COVID. So that's a bidirectional connection to the Arizona Pre-Hospital Information and EMS Registry System. That's a mouthful, so AZ Peers is easier, which is a quality assurance initiative to optimize EMS care in Arizona. But the two that we've added to since the pandemic is electronic lab reporting, or ELR, and the Arizona Surge Line bed capacity reporting. So many of you have participated in the Arizona Surge Line bed capacity reporting. That's where we use coded bed data that comes through the admission, discharge, and transfer notices that are sent from hospitals to the HIE. And we pass that coded bed data over to the central logic platform, which is what ADHS has in place, and that supports the surge line. So instead of daily manually reported bed capacity numbers for 70% of the statewide admissions, ADHS has real-time bed capacity information, which has helped substantially in facilitating the overarching effort of the surge line, which allows for transfer of patients to the appropriate level of care during surges. So that helped tremendously during the summer. We really appreciate everybody working quickly to get those connections up and going. And then, of course, it's going to be, unfortunately, going to likely be needed again as cases continue to rise throughout the country. The other thing that we have implemented since the pandemic started is electronic lab reporting. That's a unidirectional connection to the state's ELR system. I only mention this because we have taken new labs that connect to us, traditionally standalone labs to date, and we bring that information in so we can get their COVID test results and alert on that and any other lab tests they may conduct. But we have also mapped those connections through to the state's ELR system. So I mentioned this as a side note. It's not the purpose of today's webinar, but if you are interested in utilizing your HIE connection to facilitate your electronic lab reporting to the state, we can handle that now as well. So some of you probably already have that directly with ADHS. It may be that in the future you want to transition that connection so that it's just all part of your HIE connection, but that is something we can do today as well. So that's what we have already. The thing that we're excited to announce this morning is that we are going to be, because of 2 new funded opportunities, we're going to be developing ways that your connection to the HIE can support e-case reporting and can support the daily hospital reporting that you currently provide to EM Resource, which is a Juvari application. So we have named these services as part of the suite of health current services. So the service, the new service name is RISE, for what we're calling Reporting Intelligence System for Emergencies. So RISE is going to be the service that will replace your EM Resource daily reporting. And then the one that will be able to do electronic case reporting is going to be called Communicable Disease Surveillance and Reporting, or CDSR. So these are 2 new acronyms that we will use going forward for these 2 new services. We do have fact sheets on both of these new services, and we can send those out along with these slides afterwards. We did distribute them in the last week, so you might have seen them when information came out about this webinar. So the benefits of these new services is that the intent is that we'll significantly reduce hospital reporting burden. I've heard anecdotal accounts of the amount of hours and staff members that it takes to provide daily reporting to both state and federal resources for COVID-19. Additionally, those reporting requirements do change occasionally, and that increases changes that are needed to run data differently. So if we can get all the necessary data in the feeds to the HIE, then we can absorb the burden of when those things change. As long as we've got the data that's needed, we can provide updated information to the state. And then I know that ADHS has completed a connection so that if hospitals desire to utilize it, ADHS can report on your behalf to the federal teletracking system as well. So reducing hospital reporting burden is really significant. And I think that one of the reasons we got one of the federal grants that we got is because there's an acknowledgement of this and a desire to find alternatives for this type of reporting going forward. We think there's an opportunity for improved data reporting, gets data from your systems to ADHS in a much more timely manner because it does not rely on additional data extracts, manual calculations, manual reporting. And the target is to improve the timeliness, accuracy, and completeness of all that hospital reporting that's needed during an emergency. So it reduces your burden. It gets ADHS what they need to be able to support the community in the pandemic. The benefit of leveraging the HIE, we want to continue to provide as much value as we can to your organizations and to the entire community. So it can demonstrate, continue to expand and demonstrate that value of the HIE serving as an intermediary. And of course, related to improved data reporting is improved public health response. That will optimize delivery of needed response to the entire community, and everybody should be seeing benefits from these new services. So I'm going to talk about each project one by one. Again, if you've got questions, please type them into the comments. Or I haven't been on WebEx in a little bit. We're all used to our different technology platforms. If there's a way to raise your hand, we can call on you when we get to the Q&A section. But again, RISE stands for Reporting Intelligence System for Emergencies, and it's really designed to support the healthcare community with enhanced public health, really automated public health reporting during times of crisis. The reason we're calling it RISE is because there could be other purposes for which this new service line could be used in the future. Certainly the one we're focusing on right now is COVID, but if there's another crisis in the future, we can utilize the same structure to pass the information that's needed. So it really is automating the EM resource reporting. So current reporting is that manual reporting identified by this large yellow arrow. So hospitals do have connections to the HIE, and we will form the connection to EM resource so that essentially that yellow arrow gets either significantly diminished or goes away completely if we can get all the data to flow through the HIE. This was alluded to earlier, but you all know better than we do that you're required to report certain data elements for federal reporting purposes and by Arizona executive order. And there's lots of detailed information that has to be reported. It's not exactly the same what has to go to the feds and state officials, but it is similar, and it can rely on a lot of the same underlying data elements. And then there's the new interim final rule that requires COVID-19 federal reporting and includes significant monetary penalties. So that ups the ante in terms of how important it is to make sure that this reporting is completed. And obviously, we want to do everything we can to support you in that. So the service would expand data sets that are sent from hospitals to the HIE. So we would first leverage everything that hospitals are sending us today and see which of the reported data or required to be reported data elements we can check the box on just by data we already have. But likely we will need to enhance data that is coming through in electronic health record connections, or expand to connecting to different systems within your facilities and your organizations if certain data elements are not native within the electronic health record. So this is just a listing of the expanded data sets that we would look to make sure that we can capture at the HIE so that we can facilitate the provision of that exact same data to ADHS. And again, we would serve as your intermediary in this service and report that data on your behalf to the ADHS EM resource system. The implementation plan for this project specifically is a 2-year work plan. This project is funded by the Office of the National Coordinator for Health Information Technology within Health and Human Services at the federal government level. And it's a 2-year project that was funded in late September, so it'll go through the fall of 2022. And it's planned that the whole overarching goal of this project is to serve a total of 8 hospitals and health systems. And we do it in 2 phases. The first 4 we will use as the pilot phase to demonstrate that all of this data can flow and that we can complete the implementation to EM resource on your behalf and complete that reporting on your behalf. And we're looking for those first 4 hospitals to be 2 hospitals or health systems from a metropolitan area and 2 hospitals or health systems from rural areas, hopefully including a tribal facility. We need to get your commitment and your interest in this. So we'll talk about an interest form at the end of this presentation. And then our staff would work directly with your facilities to ensure that the data fields are appropriately mapped and to expand interfaces and to go forward from there. For this project in particular, actually for both projects we're talking about today, an interested hospital or health system must have a current interface with the HIE sending real-time ADT and lab data. We hope that we can continue expanding this service over the next 2 to 3 years. So if you don't have an interface with us, you can't sign up initially, but that doesn't mean we can't serve you down the road. So it's an incentive to go ahead and make sure that that data is flowing to the HIE and then express to us that you have interest to participate in this program. But anyone, especially those who are in the first phase of this project, those first 4 hospitals, have to have current interfaces, have to have the commitment and involvement of their electronic health record vendor to complete the necessary data mapping, to do standardization of data according to the ADHS specification. You have to commit to building additional interfaces as needed for sending non-clinical data elements. We request that you participate in weekly project status calls, contribute to monthly project status updates. This is a federal grant, so we are checking in regularly with our federal oversight partners, and we have to report to them regularly. And we need really a commitment of resources for the entire project period, which would not exceed 12 months. I mentioned this already, but this funding does come from the federal government. It's actually the funding we received is to reimburse for new resources we have at Health Current, but we're actually contributing a fair amount of in-kind resources from Health Current to this project just because of the limited resources that were available. This is about a $500,000 grant to cover 2 years, so it barely covers the resources that we need on our side. But you can see what the purpose is here: to strengthen and accelerate innovative uses of health information via HIEs. And they really are focused on demonstrating the value of HIEs through this project in the response to or recovery from public health events such as the COVID-19 pandemic. So that's the first project. The second project and new service that we are initiating is called CDSR, which stands for Communicable Disease Surveillance and Reporting. This one has actually been in the works in planning stages for a little bit longer. Your facilities, as well as other healthcare providers throughout the state, are required by state public health to submit case reports on certain diseases to ADHS. And the goal here, we've actually been talking with ADHS about this for several months, actually, I would say several years, because there's been an interest in how we could automate this process. But for several years, there really wasn't federal standards around this, which made it difficult to consider implementation. But ADHS let us know late in the spring that they were interested to use some of their CARES Act funding to actually initiate this project and design an approach to have a standard way to take data from an electronic health record, pass it through the HIE as an intermediary according to federal standards and national standards rather, and forward it to ADHS. So this is, again, using the HIE as an intermediary between Arizona hospitals and ADHS and passing data through for specific disease case reports. So again, the reporting requirements is that it's mandatory that communicable disease cases be reported to ADHS when identified by a healthcare provider, hospital, or laboratory. And these are requirements in accordance with CDC message mapping guides. This project specifically will look to standardize and normalize electronic case reports from EHR systems, capture those cases, move them through the HIE network, and deliver all that data in a single feed to ADHS's electronic surveillance systems. So this is an approximately 18-month project. Funding is anticipated to end in March of 2022. Similar to the RISE project, this project is supporting, the target is to support a minimum of 8 hospitals and health systems during that time frame and moving that forward. So the service, again, will reduce the reporting burden, and we would use data currently housed in the HIE that would be standardized in an HL7 message and transmitted to ADHS on behalf of those facilities. So each project basically has two phases. This one, in phase one, we select 2 hospitals or health systems who we work with those 2 to choose 6 of 10 reportable conditions to standardize in this first pilot phase. And then we work collaboratively to normalize the data, to move it through the HIE and deliver that information to ADHS. And then phase 2, we would expand to an additional 6 hospitals and health systems, and we would scale that project. Similar to the other project, in order to qualify for participating in this, you do need to have a current connection with HIE, be sending data in real time to Health Current. You have to have an electronic health record that's compliant with federal HL7 electronic case reporting standards. This is a little more technical for those of you who have the technical background. The electronic surveillance system at ADHS will ingest and accept CDSR formatted data in accordance with HL7 standards. And then we would use, again, big acronyms here, Reportable Conditions Knowledge Management System and the Reportable Condition Trigger Codes during the setup of the triggering mechanisms. And similar to the other project, we would need your organization to participate in regular project status calls and contribute monthly and commit resources to the entire project period, which is anticipated not to exceed 9 months. Now, these projects don't come without the need for both human resources and potentially financial resources if your EHR vendor would charge you fees. We are working to finalize, and I'm hopeful that we will be able to let you know the amount of the incentives that we will have available by the middle of this week. But both projects, one project for sure, but I'm hopeful that we can structure it so that both projects will include a financial incentive to offset your resources in conducting this activity and completing the connection. For those of you who participate in the HIE onboarding program that we have, the incentives that we are able to offer for these programs would be split into 2 to 3 milestones. Likely one portion of incentive would be paid when you have a kickoff call and you commit to the scope of the work for the project. A second milestone would be paid when data is flowing, and a third milestone when the project is completed. Something along those lines. Each project is a little bit different, so we're working out the details of what those milestones would be. The milestones, just to give you a sense, for the HIE onboarding program was about $20,000 per hospital or health system. I'm hoping, and again, I'm working to finalize as quickly as we can, that the incentives for these projects will be substantially more than that. So, and you would be able to, we're hoping to design it so you could actually participate in both projects if you wanted to and get incentives for each project. So again, we will confirm this in the next couple days. We'll make sure that everybody on this call gets the follow-up information, but we do recognize that there is effort that has to be expended, staff time, and potentially even vendor fees. And we're designing those incentives around what we anticipate that effort would be. Selected participants, or so selected hospitals, would sign an amendment to your participation agreement, similar to what you did with the HIE onboarding program, which would detail out the financial incentives and the milestones and the deliverables. So this is what we're looking at for the reporting potential for the future. Just to give you a sense, these are the 4 systems that before the pandemic, we were again only connected to 2 ADHS systems. And with the addition of the RISE service and the CDSR service that connect to EM Resource and for eCase reporting respectively, we would then be connected to 6 different public health systems, which again further goes to support your organizations in making one connection to the HIE really support multiple end requirements for you. So I told you I'd keep this short so we had plenty of time for questions. So we're only about halfway through our time, and this is our last slide. The next steps are to complete and submit your interest form by next week. We want you, we intend to select the initial hospitals to participate by the beginning of December. We're going to look at several things. We want to be able to support as many of your organizations as possible in getting connected to these new services. If we get overwhelming response and we have to make some decisions, we will look at things like making sure we can meet our rural and our metro requirements for the grant, looking at the current data quality, making sure that you've got the commitments of your vendor and that there's certifications in place, especially for those e-case reporting requirements. And then we will let you know that we would love for you to participate, get that confirmed, and then we'll work on scheduling kickoff meetings. So that's what we really have for our presentation this morning. Peter Steinken is our Director of Community Engagement. He's the one that interest form should go to, and is also available outside of this meeting if there's any additional follow-up that's needed. But really, that's what we had to present to the group this morning. I think I maybe saw one thing come in via chat, so let me check that. And if anybody, we don't have too many people on the phone, so if anybody does want to come off mute and ask a question, feel free to do that, and hopefully we can minimize the background noise. Is there potential to commit to just one project and not the other? Are they totally independent for CDSR? Well, we know which morbidities will be chosen for the pilot or the trial, what resources from the hospital side would be needed. So let me take those questions one at a time. It is potential to commit to just one project and not the other. We wanted to offer an option that you could do one or the other, or you could do both. The reason we thought there might be some value in doing both is, number one, you could get additional resources if we're able to have incentives for both projects, so you kind of get double incentives. Plus, sometimes when you have to go back to your EHR vendor and ask for modifications to data feeds, ask for additional data to be transmitted, it's easier to just do it once than to have to work on this project and then have to go back later. But we certainly want to accommodate what's best for your organization and your facilities. So if you prefer to do just one, that's no problem for us. So they can be totally independent. If you want to do two and you'd like to do them together, you can let us know that as well, and we can try and line that up as we're going through and seeing who's interested. For the communicable disease surveillance and reporting, will we know which morbidities will be chosen? What resources from the hospital side would be needed? Excuse me, I got the hiccups for a second. Let me go back to the slide on that because this one says, choose 6 of 10 reportable conditions to report. If we've got Keith Parker, somebody, or Peter may know this answer too, my understanding is that we want everybody to choose from a list of 10, but depending on what's most important to your organization, as well as what your EHR vendor can comply with, you would have some flexibility in which 6 you choose. So that there can be some flexibility. I know there's many reportable conditions, so we're balancing the requirements of the certification and the standards around certain reportable conditions. So we don't let everybody choose 6 out of 60, but there is my understanding is there is it is able to be some flexibility in there. Is there anybody on the phone? Did you want to? Oh, go ahead.
Yeah, I was going to add something, Melissa. So this is Keith Parker, the CIO for Health Current. So that is correct. We are trying to limit the number, and we're working with ADHS to get what that list of 10 would be, so the hospitals can choose. The other piece of that is, from a technical perspective, we don't want really broad variation because there's well over 100 different conditions or electronic case reports that CDC has available. So we want to narrow it down so we can work through the first and then scale from there as well.
Thank you. And can you speak to, Keith, the last part of this is what resources from the hospital side would be needed?
So resources from the hospital side are going to vary depending on the systems that you have in place and how many systems you need to work through, as well as your staffing. If you have a strong IT support staff that can do the integration and the mapping coming through your integration engine, it's going to be those types of resources. We're also trying to work from the health current side. We're bringing on additional analysts to be able to support some of that mapping as well, so we can get it over. The other piece of that is our hope is this also goes back to reducing the number of conditions or morbidities that we're looking at, is we want to standardize how we can move this across hospital systems as well. So the resources will vary from system to system depending on the EHR and the applications that you use. But at the very minimum, we're going to need individuals from an analyst perspective that understand how you code the required data sets to meet those conditions and how you get them through your interface engine into a message to us, and then support us in how we code to standardize across all hospital systems to get it into one feed going to ADHS.
Hey, Keith, if folks have individual questions, could we have them contact Peter and we could connect them with somebody on our team? Because I know you all have more, our technical teams have more insight into what might be needed for different types of vendors.
By all means. So going through Peter or myself, and we will get the right technical people involved.
Great. I think ASHA has a comment they wanted to make. Are you there, Anne-Marie or Debbie, or someone else?
We are both here. Can you hear us?
Yes, we can.
Oh, great. Okay. Yeah, Anne-Marie Alamadine and Debbie Johnston from ASHA here. And I just really wanted to, I'm sure there's a lot of detailed questions that hospitals have, but just recognize and appreciate the tremendous amount of effort that Health Current has done with respect to these really important projects. We heard so much concern from the hospitals in terms of being able to comply with the new data reporting requirements and the ever-changing data reporting requirements. And we're just so grateful to have a resource, a community resource like Health Current that can really be activated and deployed for this work. This is truly, you're answering a call that I think so many hospitals have, and just appreciate your efforts in this area.
Great, thank you, Anne-Marie. We're excited to work on this, and I think it's a good example to set for other states.
And although I know we're focusing on the two discrete projects, we'll mention that we are looking forward to additional conversations with you, but that ASHA is in receipt of some federal COVID monies that we will be dedicated to helping alleviate and to strengthen and support these data reporting enhancements.
Absolutely.
So that hospitals know about that.
Great. Yeah, and that's why we're kind of solidifying the details around those incentives. Look forward to talking with Anne-Marie and Debbie, I think later today, to see if we can solidify some of those details so we can be clear in the combination of funding sources and how they can support all of your organizations. There was another question in the chat. We're in the process of going live with ADHS for syndromic surveillance. So would CDSR be of any benefit to us? I am not, I love public health, but I'm not a proclaimed public health IT expert. I believe, and I'm going to ask Keith or anyone else, if there's somebody from ADHS on the phone, to chime in here. But I believe when you talk about going live with ADHS for syndromic surveillance, you may be referring to connecting to the BioSense system. And this project would be connecting to the MedSys system. So I know for syndromic surveillance under the new promoting interoperability, what used to be meaningful use, there are connections to CDC's BioSense system, but this is a different initiative. So I believe that they're separate, but we would be happy to follow up with UKC and confirm 100%, because we certainly wouldn't want anybody doing duplicate effort. Does anybody else on the phone have any insight on that they want to share?
So a little bit of insight, Melissa. Again, this is Keith. It's probably worth your while to look into doing both, because one of the things that we're looking at working with ADHS is how do we move forward, not just with standardizing data sets as it pertains to one program or another, but how do we set up channels that standardizes data sets across efforts, whether it be BioSense or the electronic case reporting or the hospital reporting. So from that perspective, it may be worth it because a lot of times there is crossover in how these data sets are developed and standardized to be able to move. So there are good implications, or there are good reasons to look into joining both.
Great. Those are all the questions in the chat so far. If anyone wants to, please feel free to unmute and provide a comment or ask a question. We'll give it a few more minutes and see. Sometimes if you've got a burning question, it takes a little bit to type it into the chat. So we'll give a few more minutes. While we're waiting to see if anyone has any other questions, I would just reiterate that in order to confirm, I'm going to ask Peter to unmute because I wasn't, I want to make sure I get the date right. But Peter, can you confirm which date it is that everybody needs to submit the form by? Is it what's on this screen, the 19th?
I have on my calendar, it is the 16th.
Okay, that's what I thought. I thought the interest form here, I apologize for that typo. So we're hoping to get the interest forms back in a week. These projects, you know, are time limited. Again, this is to express initial interest. So just because you don't get it in by the 16th, if you have interest on the 17th or in early December, please still submit it. But if you're really interested in being one of these first pilot projects to work on this, we really do need it back as soon as possible because we do need to move forward with both projects in order to meet the grant and the contract requirements. And then we would get in touch with you and let you know if you're in the first phase and the second phase or what the next steps are. If you're in the first phase, as identified, we would have you sign something to confirm the incentives that are available. And then also we would work with you and your team to identify the right people to participate in the project and to schedule those kickoff meetings. So that's really the next step. We are really excited about this project. And again, if you have a question now, please chime in. Or if anybody on the phone from our team, if there's anything that I missed, please chime in. And then we can always wrap this session up a little bit early, give some people some time back in their day. And Peter's always available for additional questions you may have after this session.
Hey, Melissa, this is Peter. I just wanted to make a quick plug as well to our electronic lab reporting connection we have with ADHS that you spoke about earlier. Mm-hmm. And if any of these participants are interested in that as well, you can email me. I put my email in the chat. That's just another one of the 6 connections we have with ADHS. It's not one of these 2 specific projects we're talking about here, but if your hospital is looking for a solution there, we can help with that as well.
Great, thank you. All right, any other questions? Look at the participant list here. Okay, we will remain on the line for a couple minutes in case anyone has any final questions, but for everybody else, if you're all set and you don't have any questions, you're welcome to go ahead and disconnect. We really appreciate your participation in today's session. We hope it was informative. We're very, as I mentioned, very excited about this opportunity to work with your organizations. And we'll make sure that these slides get out to everyone who participated today. And as soon as we have some confirmation in the coming days about how the incentives will work, because I'm sure that is certainly a determining factor in some instances, we will get that out to the group and via our regular email communication channels and via ASHA as well. So we look forward to hearing back from you. Please submit your interest forms and reach out to Peter. And I'll stick on the line for a couple minutes here in case anybody has any other questions. Thanks so much. Have a great day.